Welcome, dear attendees. Good morning, good afternoon, good evening in your different locations in the world. This is the second virtual spring meeting that we're having, and it allows us to join from different continents, from different time zones. So let us know where you are, what time it is, through the chat and the poll, so that we can connect in our virtual space today. We've all been looking forward to these 2 days, and a lot of work has been done by the investigators, but also in the committees. Both form the backbone of this initiative, together with our funding partners and our staff. So many of you have attended before and look forward to meeting almost as old friends. Others of you are new, and do let us know if you are through the poll, because we want to welcome you very warmly today. We expect over 200 attendees from over 40 countries. Together we form the supporters and the fans of leprosy research, and we will receive the updates from the scientists involved in this research. We will also learn more tomorrow about LRI's plans for the future. Among other things, we have plans to support the development of new investigators, which is really important for our field. Our strong international initiative is effective in pooling funds, in having shared priorities across the world, and by ensuring quality research. And our strong connections with the Global Partnership for Zero Leprosy makes our work even more powerful. We share one goal: achieving zero leprosy, a goal we can only achieve as partners. And we share this drive to do so with a focus on the solutions for the ultimate beneficiaries, the people affected by leprosy. So I would like to give the word now to Dr. Richard Truman, the chair of the Scientific Review Committee. And I wish all of you very inspiring and fruitful days ahead.
Thank you, Linda. I'm, excuse me, it's spring where I am, and so we have a little bit of allergies going on. Anyway, so I'm Richard Truman. I'm chair of the Scientific Review Committee for the Leprosy Research Initiative, and take this opportunity to welcome you to the 2022 spring meeting. This meeting is designed mainly to review the progress of all the various research projects supported by the Leprosy Research Initiative. It's also intended to be a forum for the exchange of new information from established scientists and young investigators, as well as a platform for facilitating networking and hopefully developing new synergies. Over the next 2 days, you will hear 32 formal presentations in topic areas of major importance to leprosy. These include early detection and diagnostics, reactions and treatment, stigma and mental health, and transmission and prophylaxis. Each day will begin with a plenary keynote address, which will be followed by focused research presentations and 2 simultaneous parallel tracks. We'll close out today with another keynote address, and tomorrow with some closing comments. I'm sure you've already reviewed the online program and decided which talks you want to hear and when, but if not, you can still do that through the program tab and as the program progresses. After 2 years of pandemic Zoom meetings, I know we're all pretty well versed in navigating online sessions. Each platform, though, has its own specific traits. In this current live stream feed, you see a number of tabs on the left side of your screen. You can switch between them, and I'm going to describe them for you. The Q&A, chat, and polls tab, which Linda's just mentioned, these are posts that are visible to the moderators. This is where you should post your questions to the speakers, as well as respond to those polls. And you can take a look at those. I think there's one up already about time zones or where you are, so forth as that. The next is a general chat. Posts here are public and shared with all the attendees. That's followed by a participants overview showing who's logged on, and a one-on-one chat where you can exchange text messages or video calls with another participant. Finally, there's a Connections tab where you can post business cards. For the progress presentations running in parallel, you'll find 2 yellow buttons and a blue banner below this screen. want to say join track A or join track B, and clicking one of those, you'll be directed to that session. Within each of those breakout sessions, you'll again find it has its own Q&A chat, as well as an overview of the abstracts of the projects that will be discussed in that session, and other tabs like I described before. During the coffee breaks, you'll have the opportunity to network with fellow attendees. You can do that either in a one-on-one chat and video call, or by making use of the network carousel. The network carousel will randomly match you with another participant with whom you will have a 3-minute video call. It's a way to meet people. Give it a whirl. If you have any technical issues, please contact the help desk at Activo. Their contact information is supposed to be posted in the chat, and hopefully things will go smoothly. Since we are a bit quick in our takeoff at this point in time, maybe you want to try the chat now. Everybody can sort of key in, say hello, and tell us where you're joining from, what country. So with that, then we'll just go ahead and start moving towards our keynote presentation for this morning. It's going to be by Dr. V.R. Pemmaraju. Dr. Pemmaraju is a medical doctor. He's currently working as the acting team leader of the Global Leprosy Programme at WHO. He graduated in medicine and did postgraduate work in tropical medicine and public health. He's experienced in clinical and health program management.
Thank you, Dr. Richard Truman, and the colleagues from Leprosy Research Initiative for the opportunity to present the WHO's ongoing work on guidance for countries to verify interruption of transmission and elimination of leprosy diseases. The need, in fact, arose from the request from countries which have very low burden to be recognized by WHO for having a goal like zero leprosy status. And it decided very well with a release of Global Leprosy Strategy 1, which is a part of NTD roadmap. There was a paradigm shift from in terms of its targets, from elimination as a public health problem towards interruption of transmission or elimination of leprosy disease. In the previous goal, elimination as a public health problem was considered as the target, and reaching a stage of one active case or one case as prevalence for 10,000 population was considered as a target. It's no more recommended by WHO. And this verification for interruption of transmission is advocated at subnational levels to be done within the country by the team of experts, and at national level by a team of experts from international team constituted by WHO. In order to develop this guidance, a task force was created in 2021, essentially with the purpose of proposing definitions, identify cutoffs for achievement of these different phases, set criteria for screening with verifiable indicators and targets. We'll review the work in progress and take your guidance. The key definitions that have been included in the new guidance are, which were not earlier used in the leprosy program, or the autochthonous case of leprosy, which is presumed to have got infection following local transmission in a reporting area. A reporting area, a subnational area, or a country. On the other side, on the contrary, the non-autochthonous case is a case of leprosy whose infection is assumed to have occurred in the country of birth, and epidemiologically these foreign-born cases are not considered part of the local chain of transmission. The sporadic case, occasionally new cases that occur infrequently or irregularly in a given area, and which are not to be related, which are not found to each other. For example, it's not an index case, or a secondary case of an index case. Other definitions of endemic status, constant presence or usual prevalence of autochthonous leprous agent in a population in a geographic area. In terms of leprosy, its presence of an autochthonous leprosy case is considered endemic. A non-endemic autochthonous cases have not been detected, and only sporadic cases in the population for 10 years or more. After 10 years, the area of the country moves into a non-endemic phase. Child cases, no new autochthonous child cases among children for at least 5 years. In leprosy program, child case is a person with less than 50, and the indicator that is used is number of new autochthonous child cases, and they have to be 0 for consecutive 5 years in a subnational jurisdiction or at national levels. Other indicators for this interruption of transmission phase used are new child cases in terms of number and proportion of new cases, new case detection rate among children, that is child case rate for million child population in a given area or in a country, multibacillary percentage among new cases, and in addition a new indicator is suggested or proposed is seroprevalence of Mycobacterium leprae infection among children of 6 to 7 years of age, that is presence of anti-M leprae PGL1 IgM antibodies. Though more research is needed, it is proposed in the technical guidance. The milestone, the cutoff indicator for elimination of leprosy disease is number of autochthonous new cases. There have to be zero new autochthonous cases for consecutive 3 years. And when we say new autochthonous cases, it's all ages, including adults. The other indicators that are used are new case detection rate, again autochthonous cases per million population, proportion of non-autochthonous cases among total new cases detected, and rate of new cases with grade 2 disabilities per million population. To prepare the national programs, in WHO, the annual data collection tool has introduced a collection of data on non-autochthonous cases with clear definition, as we discussed earlier. And countries have started reporting for the past 3 years, collecting data and reporting on non-autochthonous cases in their new cases. These are the journey a country has to pass through in the elimination of leprosy, and most of the countries are in the stage of phase 1. That is, the countries would have crossed the stage of elimination as a public health problem, and that's why it's not been in the whole journey. The journey is countries are moving towards interruption of transmission, and then further they will move towards interruption of transmission to elimination of disease. After reaching elimination of disease, a population surveillance is suggested for 10 years. After post-elimination surveillance, the countries will move to non-endemic status. To describe each of these phases, the first phase of that is until interruption of transmission, there should not be any new autochthonous child cases for at least 5 consecutive years. Then only the subnational area or the country would move into the phase 2 and proceed on to elimination of disease. The elimination of disease is achieved when a country reports no new autochthonous cases for 3 consecutive years and no child cases for the last 5 years. When a country or a region passes through area, subnational area 2, phase 1 to phase 2, a verification is proposed. And this verification is done to verify the cutoff if it has been reached by the subnational area and other programmatic criteria through a tool called Leprosy Program and Assessment Tool. The same tool would be applied for verification of elimination of leprosy disease. A bottom-up process is suggested in the whole diagram. For a country to reach elimination of interruption of transmission, all subnational units have reached the stage of interruption of transmission. So every subnational unit has to do its verification and demonstrate detection of no new or 0 new autochthonous child cases for at least 5 years. Once all subnational units have reached that stage, the country will be in a stage ready for verification for interruption of transmission. Similarly, in the phase of elimination of disease, all subnational units have to be verified by an international team to make the country declared as acknowledged as eliminated leprosies. Having reached that stage, for next 10 years, the country needs to demonstrate to have a strong surveillance system sensitive enough to detect the sporadic cases. In this stage, only sporadic cases are expected for a period of 10 or more years, and if sporadic case is detected, it has to be critically investigated with a given investigation format so that it is not related to another sporadic case and it's not an autonomous case. Non-endemic status, only sporadic non-autonomous cases only will be detected. So this is the schematic diagram where the countries have to pass through for reaching the goal of elimination of disease. The proposed cutoffs have been decided after reviewing data of 4 countries at subnational level. One of such data is presented here for Maldives. The data of adult and child cases, autochthonous cases, are applied onto Excel sheet, and graphs are developed. And this graph shows from the year 2000 to 2020, the number of adult cases and the number of child cases detected. Maldives, a low endemic country, had a highest detection of 17 in 2003. Otherwise, most of the time, the number of cases detected are less than 10. For the past 5 or 6 years, the number of cases are even, and in 2020, 3 cases were detected. The linear trend shows it might, if the same situation continues, it might reach 0 autochthonous adult by 2025. The blue line, which shows number of children detected for the past 20 years, the number of children were 0 from 2006 onwards. 2010, it would have theoretically been achieved interruption of transmission. But in 2000 and again in 2013, 2015, 1 child cases has been detected. And after 2015 and between 2020, there is no child case has been detected. Now, in 2020, Maldives would be ready for getting verified for interruption of transmission. To make the presentation much more in the phases, is presented by subnational using an elimination monitoring tool and the color code that is being used for different phases. I will describe about the Gafu Alif et al. In the first row, which has reached a level of interruption of transmission in 2008, because from 2003 to 2008, there no child case has been detected. After that, between 2008 to 2017, no case has been detected, excepting 1 adult sporadic case in 2011 and again in 2017. So this et al. Moves to the phase of post-elimination surveillance. The one in the purple stage, it shows here that it's a sporadic autochthonous adult case. So this has to be critically investigated if it has got any relation with in another new case within the next 2 years, and then the phase will reverse back to interruption of transmission. For paucity of time, I'll just review only 2 or 3 et al. The et al. In the rule number 4, Gaviani et al., Gaviani-Sini et al., where no cases were detected. It has, from 2000 to 2020, it has moved without any new case, new autochthonous or sporadic case, into the phase of non-endemic status. At the country level, it is a situation is that there are no new autochthonous child cases from 2016 onwards, but there are autochthonous adult cases every year detected in the range of 3 to 7. So the review has to happen for all atolls and all islands under the subnational unit, and then only the verification can happen for interruption of transmission for the whole country. Similar analysis for Morocco data. Also here we see, I will describe about Tarfaya prefecture. Here in Morocco, the first subnational level unit is called prefecture, and the second subnational levels are called provinces. In Tarfaya province, the province has reported 0 autochthonous child cases between 2002 and 2006, but has detected 1 child sporadic case in 2007. But after that, there is no child case detected, so it continued in post-elimination surveillance, and it can theoretically move into non-endemic status. So this is the data which we have used for proposing the criteria, and more work is required to use this data in more countries to make it much more stronger proposed indicator or cutoff for interruption of transmission and elimination of disease. Just reaching the cutoff, epidemiological cutoff necessary, is not sufficient for a province to be acknowledged as having reached interruption of transmission and elimination of leprosy. The task force on definitions and criteria have met, deliberated on various issues, and have identified 14 criteria to be verified with verifiable indicators and targets under each category, under each criteria, and make sure that these criteria are present when the cutoff indicator has been achieved, or when 0 cases have been achieved. For purposes of time, I will go through the 2 criteria for calculation. One is hours of leprosy and contact tracing. This is how the verification template is proposed. Work is in progress in this area. For achieving 0 transmission, 0 leprosy disease, awareness of leprosy in the general population community is the criterion that need to be verified. And coincidentally, this is one of the challenges that have been identified while defining the Global Leprosy Strategy 2021-2030. The intervention that has to be present on verification these are examples: awareness raising among targeted populations. It could be general population through mass media, or locally in hotspots for at-risk people, that is contacts or people living in internally displaced camps, and special population groups like school children and students. The verifiable indicators are number of awareness activities conducted by the area, and the target set is 1 awareness raising activity should have been conducted in the district per year, or 1 awareness raising activity should have been conducted in the hotspot per year. Another indicator to substantiate awareness is level of leprosy related knowledge. That is, example, percentage with adequate knowledge, with the target of the community. In the community, there must be more than 60% adequate knowledge about leprosy related issues. Another criterion for discussion purposes under the same area of 0 transmission disease, we can examine the contact tracing, which includes activities like obtaining consent from the index patient and the household contacts for doing contact screening. All contacts should be listed, including household, neighbor, and social contacts of all cases that were detected for the past 5 years. The indicators are mean number of contacts listed per index patient, and the target that set was 20 or more, depending on the setting. In some countries, neighbor contacts and social contacts are included. That's the reason why, and only household contacts are included. So they can vary from country to country. Another intervention that is required to be verified, these are only examples, there are a few more, which can be done during the verification. Screen contacts annually for 5 years. And percentage of examination of enumerated contacts should be more than 80%. All these criteria and available tools are used through tools to verify the status of interruption of transmission. The leprosy program and transmission assessment tool is being developed. and it will contain all the 14 criteria, different indicators, and will be piloted in a few situations or countries. And for the subnational levels, this tool will be shared with the national program for doing a verification, either for interruption of transmission or elimination of leprosy disease with the experts. Of course, this will be supported even at subnational levels by WHO and ILAP partners while doing the assessment. At the national level, the verification will be done only for elimination of leprosy disease, and it will be done using a group of experts drawing from different different backgrounds for verifying and acknowledging elimination of disease. For verification of acknowledgement, the countries have to through a dossier which would give information about the country and the leprosy program and demonstrate the evidence that transmission has been interrupted in all subnational units and at the national level. Again, a bottom-up process will be structured through this in the dossier, and there are no more autochthonous new cases other than sporadic cases are detected in the country. And particularly the services for disability care are continued so that persons with disability are not lost out of sight, and inclusions are in place. The suggestions are made by UN principles and guidelines or accepted or adapted in the country. And these are all compiled as a bottom-up process by second subnational level like provinces and to regions or prefectures and then to country. And this dossier will be the basis for verification process at the national level, and it will be used by a team of verification for doing for declaring a country either has reached elimination of leprosy. The process, the whole documents are being developed. This will be reviewed, and we are looking for volunteer countries requesting them to use these program tools, and so that the elimination or leprosy program assessment tool is much more robust and stronger for use in the programs. We acknowledge this support, the contribution by the TEFSL, particularly the chair, Dr V.R, and the members of TFCEL, and also the WHO staff, and also the people who are experts who have contributed to developing this document. Thank you.
Thank you, Dr. Pemmaraju. We can ask the participants to load any questions into the chat box at this point in time. If they haven't done so already. I do have a question for you of my own, and I guess it's esoteric in some regards, but what exactly is the definition of autochthonous in these circumstances? Does it include any aspects of foreign residence history, having foreign relations, or anything such as that?
Yeah, non-autochthonous. Thank you very much, Dr. Truman. It's a very important question, and it's being discussed at length by various people. The non-autochthonous cases is a person who was born in a different place, come to an epidemiological area where he or she is being taken treatment, and presumed to have acquired infection in the country of birth. That's how the definition has been made, and we have been in discussion with the countries whether this stands very well. There are certain areas where this is further discussed, particularly when the travel occurs more and more between the endemic countries and non-endemic countries. It's quite difficult to define the transmission happens. Particularly so when the transmission dynamics is quite unknown, or there are many unknowns in the transmission dynamics. So every case has to be investigated, both in terms of the history of exposure and travel to endemic countries and having got the initial symptom. So it's going to be quite a process when we define a case as a non-autochthonous case. In some situations, it's quite clear. For example, I'm giving an example, just for example, the countries between Nepal and India, we see regularly people going across the border and taking treatment. So their situation to define basing on the address. but it makes much more complex when people travel far to the endemic countries for different purposes and come back to a country where there's no leprosy, and that's where the situation is very difficult. Thank you.
Yes. Well, we have another question too, and it's this one is from Dr. Gobina, and it's adequate knowledge is a concept. How is it measured? What is the cutoff point to say adequate or inadequate knowledge for leprosy?
Yeah, no, that's very important. I think what the leprosy program assessment tool has devolved is a set of questionnaires and understand knowledge about early signs, places to report for treatment, and how the treatment is given, whether it's treatable or not, and also include components of stigma and discrimination, so that there is an element of adequate knowledge detected. But it's very difficult for each individual to say how much a person has got knowledge, how much it is used at the time of appearance of a suggestive symptom of leprosy. So it's a collective tool, but the tool is assessed in a community. So it's more whatever the knowledge in the community we know about leprosy, that's been measured. And it's very difficult to clearly demarcate this is the cutoff of how much the person is aware of leprosy.
And we have one similar question that we could answer very quickly would be, what are neighboring countries, from Dr. Witten? What are neighboring countries? Is there a definition? Are you doing like joins of borders or frequency of travel or what?
Yeah, we are mapping out. This is the current situation where we are monitoring for the past few years, where people move from one country to another country, take treatment, and come back to their routine place of stay. And it's only introduction of this definition of autochthonous and non-autochthonous makes the documentation much easier, and countries to register patients as non-autochthonous cases. But what we ensure is sustaining treatment in wherever place, it's this side or that side of the border. It has affected in a few situations where more than 25% of new non-autochthonous, because the supply, MDT supply, is dependent on the number of cases detected. So that's how we are watching it.
Good.
And that's how we will be evolving more solutions for addressing these issues. In a different situation on this, there are people who are migrating, or people found in internally displaced camps. That's being another complex issue, migration within the country. So there's much more to know, only to ensure that every person detected gets complete treatment. Sorry for interrupting, Chair.
Mm-hmm. No, so from Dr. Diana Lockwood, she indicates that she's worried that defining people as having non-autochthonous cases defines them as outsiders, and so makes them different. And she wonders if this doesn't present a human rights problem.
Yes, this thank you, Dr. Diana Lockwood. I think this point has been discussed because it clearly differentiates from the other group of people, and that's something that has to be done while making the documentation at the time of registration. And this has to be taken care of. It's important that the designated treatment centers so that everybody's seen at the same level without marking them as non-autochthonous cases. Yes, this is an issue which we have to train the countries with the treatment centers while providing treatment.
And I have one more comment and question from Dr. Bouk-de-Jean, who says it's an important and practical tool for areas with uncertain incidents. Would you recommend contact investigations, door-to-door screening, or otherwise?
Yeah, thank you. I think in the strategy, active case finding and integrated approaches is recommended, particularly in those low endemic areas. And in high endemic areas, campaigns are advocated so that everybody is aware of leprosy in the high endemic area, and in low endemic area, door-to-door campaigns are advocated so that every case is being detected.
Very good. I think we need to, in concerns of time, we'll go ahead and stop it there. People can contact Dr. Pemmaraju, perhaps over the coffee break, which is what's coming up next. I also take this opportunity to remind you that the progress presentations which will ensue are simultaneous. There's a track A and a track B. 2 yellow buttons will appear, and you'll be able to choose which one you want to go to. For now, we'll be heading to the coffee break, and if you want to, you can try that network carousel or what have you. Thank you all for this morning. Thank you, Dr. Pemmaraju.
Yeah. Thank you.